Hello, everybody. This is the Healthcare Committee back again for the afternoon on April 18th. First thing that we're going to do today is we have somebody from the Legislative Council that's going to go through S65 with us. And we'll have some witnesses after that. So with that, Mary, please take it away.
Okay, for the record, Ameren Abergele, Legislative Council. I'm going to share my screen to show you S65. S65, as passed by the Senate, is an act relating to commercial insurance coverage of epinephrine auto-injectors, also referred to as EpiPens. Section 1 would add a new subchapter 15 into Chapter 107 of Title 8, which is the insurance title. Subchapter 15, epinephrine. Section 4100M, epinephrine auto-injectors, coverage required. Subsection A, as used in this section, health insurance plan means any individual or group health insurance policy, any hospital or medical service corporation or health maintenance organization subscriber contract, or any other health benefit plan offered, issued, or renewed for any person in the state by a health insurer. The term shall not include benefit plans providing coverage for a specific disease or other limited benefit coverage. Health insurer means any insurance company that provides health insurance as defined in subdivision 3301A2 of this title, nonprofit hospital and medical service corporations and health maintenance organizations. So really we're talking about our fully insured insurance markets. So individual, small group, and then the fully insured large group market. This does not include Medicaid or the state employees health plan. So subsection B, except to the extent such coverage would disqualify a high deductible health plan from eligibility for a health savings account pursuant to 26 USC section 223. A health insurance plan shall provide coverage without any deductible, co-insurance, co-payment, or other cost-sharing requirement for epinephrine auto-injectors when prescribed by an insured's healthcare provider. So as you may recall from some of our other insurance legislation, we are carving out those high deductible health plans to the extent that this no cost-sharing requirement would prohibit them from having health savings accounts. So fully insured market, sort of minus those with high deductible health plans, would be required to cover those epinephrine auto-injectors with no cost sharing. Section 2, the effective date. This act shall take effect on January 1st, 2025, and shall apply to all health insurance plans issued on or after January 1st, 2025, on such date as a health insurer offers, issues, or renews the health insurance plan, but in no event later than January 1st, 2026.
Okay, thank you. Questions?
I want to understand totally what plans must cover this. Could you review that again? I got lost in the...
Yes, so we are talking about our fully insured insurance market. So it's small group and individual on the exchange, as well as any reflective plans through the insurers. And then the fully insured large group market. So not self-insured employer plans, but the fully insured large
fully
groups.
insured plans, including Medicaid and all that, which are probably already
not including Medicaid. This will not include Medicaid. It only is covering that fully insured markets.
Okay. And so it looks like these will be just totally free for the public.
So long as the person does not have a high deductible health plan, they would not have any of the cost sharing, the deductibles, the co-pays, or the co-insurance.
Which I would think that means.
Yes.
Okay. Yeah, I'm just trying to know what we're doing here.
Yes.
Okay. All right. Thank you.
Wilson?
I'm not sure if this is a question for you, but I'm just want to understand what problem we're solving.
I don't believe that is a question for me.
Maybe someone will help me with the problem.
I think it's the high cost of the
So I just want to get it out there. I just want to understand sort of what we're doing. Yeah.
Bobby?
My question is about that subsection B with the, so if you have a high deductible health savings account type plan, this will still be covered, but you have cost sharing. You have.
Yes.
But
Correct.
it's not a question about covering the pen. Okay, I just want to make that clear. So you just have to pay for it, the whatever the copay would be.
Good question.
Yeah.
That's all insurance companies.
It is insurance companies that are providing and either a small group, individual, or fully insured large group.
That we regulate.
Okay.
Those that, yeah.
Okay.
The slices of pie that we regulate,
So
not including Medicaid though, or the state
No
employees.
I don't see any
No
Medicaid.
and no state employee plan.
Okay?
Actually, what is a hospital or medical service corporation? Any hospital or medical service corporation?
To go in and find a definition, that's our general description for that we have in statute. A lot of times when we're referring to these, I would need to look. I shouldn't talk about that. I would need to look. I don't recall offhand how it is defined.
Is there anybody in the room that can answer that
I was
question?
gonna say, maybe we should wait for our first witness.
Yes. Sarah Teachout for Blue Cross and Blue Shield of Vermont. That's describing our organization. We are a special entity under state statute. That's the description.
Thank you.
That's half of the description, right? That's half the description.
Right.
What other questions from the committee? None. Okay. Thank you very much.
You're welcome.
We appreciate that. Now we will move on to the witnesses. The first one is Michael Fisher. Who's the Chief Healthcare Advocate.
That's what they call me.
Chief.
Mike Fisher, Healthcare Advocate. Good to be here. Start with the Healthcare Advocate's Office supports this bill. It is a modest improvement. It affects, I'm afraid, a very small set of Vermonters. By the time as Ameren was just talking about the slice of the pie that is fully regulated, even more slimmed down because we're taking it out all the high deductible health plans. So it's a small set, but it is the action that's available to you. And I have a bit of a different answer to the it's free question. When is anything free?
Well, that's the only reason I asked. I thought that it was over.
Nothing's free.
Yep.
The cost of a epinephrine auto injector, I think EpiPen is a brand name, is the cost. The cost of it is the cost of it. And the question is not whether, the question is when, who is paying for it? Right. And so when we take it out of take all the cost sharing out of it, it means the full cost of it is paid for through people's premiums. Blue Cross is not putting anything extra into it. People's premiums are paying for the full cost of it. And there's a little bit of a balancing act about when does it make sense to pay for it all with the premium, or when does it make sense to apply cost sharing? And I guess my thinking is that there's times in healthcare where we don't want to disincent people from getting things that are important at the point of sale. And this is one of those where it makes sense to us. People who need to carry EpiPens really need to carry EpiPens and or epinephrine auto injectors. And so yes, it's still being paid for. It's still being paid for by ratepayers in the form of their premiums. The cost is being fully spread across the whole group of ratepayers. instead of a portion of it being paid for at the time of sale.
Everybody?
Shameless about this right now. My understanding is that, especially with the first time that the brand name, Mylan, I think, the EpiPen, the prices skyrocketed. The drug manufacturer was about 40% of that equation. The PBM was the other driver of that skyrocketing cost increase. Would, and knowing that we're still working on regulation of PBMs in Vermont, would this be something that the Office of the Healthcare Advocate be interested in, A, enforcing existing law, and B, working further to regulate PBM business in the state of Vermont around
Only with someone,
pricing and
only someone would introduce a bill about that. Yes, of course. Anything, we often talk about being proud in Vermont for having such a nonprofit healthcare system, and nonprofit major players in our health insurance and not for profit hospital system. In the world of prescription drugs and in the middle management of prescription drugs and the PBMs, there's profit takers. Because people are making a lot of money on us getting the care we need.
with no accountability or minimal accountability and no competition.
So yes, in the event we have an opportunity to come and speak about regulating PBMs, that's something the HCA would support.
Thank you.
Okay. Leslie?
So I was just looking up the costs so we could understand kind of what we're talking about, and it looks like at Walgreens, it's $108 up to $350, which is the range that I'm seeing in at Good RX. It might depend also on how many rebates happen in between the drug manufacturer and the PBM and whether that was passed on, and whether you're paying a cash price or whether the insurance company sometimes pays a higher price than the cash price.
But
and it's worth checking that out when you go to your pharmacy now, when you're getting prescription med, just for the heck of it.
But as a reminder, in the case of this bill, we're just talking about the cost sharing aspect. The cost of the medicine is still the cost of the medicine.
I just thought it was a good case.
Yeah.
Just a case study of what we're talking about in terms of PBMs, that this is.
I thought
That's lower. I
I thought I was seeing,
$700 or something. Yeah, whatever.
yeah,
I, that's what I found on a quick look.
Do you have something you want to add to that?
I thought they were higher than that. So that's good news if their
Yeah. price
is going down.
Yeah.
These are something you have to have a prescription to get?
yes.
You have to be prescribed.
And they last a year, I think. They go bad. I know about this from personal experience. My daughter had to carry them around for a long, long time. So that was before they tripled in price a couple of years ago.
Okay, so when they're one shot and done, shot they use it.
You're two in a thing.
Okay. So people that have an allergy or something, these are life-saving devices. Yeah, I know very little about it. Knock on wood, I haven't had that, but, okay. So Ari said something like 400. I'm just trying to determine, how much they are roughly and what we're being asked, all premium payers now. I'm sure these folks will have some data. But.
Yeah, I think the costs to the system, I think the next two witnesses, I think Blue Cross and MVP will have an ability to tell you a little bit more about sort of the incidence, how many people are needing this prescription. I don't have an insight into that, but I will also add, when I quickly looked it up, I thought I was seeing more in the $600, $700 range.
We'll find that out.
Yeah, okay.
Yeah, I could just comment if I may. These are, you're right, with coupons. So if you're lucky enough to get a coupon, you're going to get these. And then the health warehouse was $400. So it's all over the place is the point. There's no consistency.
But this bill would would prevent the carriers in the fully regulated market that are not high deductible health plans from having cost sharing. So it's a smaller benefit than that.
Yeah, I see what you're saying, 649. I have a couple of questions. So kind of to Leslie's question of what problem are we trying to solve? First of all, I'm trying to figure out, are there generic, I mean, I know EpiPen, but then there are other auto injectors. Are there generic versions that are cheaper?
Yeah.
There are, okay. And what other than, I'm thinking like birth control. What other categories of medications do we do this for? Specifically, the no cost share. I mean, I understand the deductible, but what other things do we say, no copay, no?
So breast cancer screening. Okay.
I'm looking at what other prescription drugs do we do this for?
I'm not able to dig it out immediately. I don't know whether a quick statute search would find it, but
Reduced insulin, but it's not
sure, we set a $35.
That's better.
a month, I think.
I think the federal was 35 and then we did 65 or something like that. So we've played in this territory of limiting cost sharing. Again, for medications where I think there's a public health interest in making sure people have access to them.
We haven't actually just totally gotten rid of any cost sharing.
I would be surprised if, I can't think of one, but I would be surprised if this was our first.
You can ask that question.
I'll ask the question of the insurance. Thank you, that was it.
Anything else, Bobby?
Well, I mean, there's lots of drugs that are necessary to save lives, but are there any drugs similar to this that where time is of the essence? Because the thing about epinephrine for me is that you only have minutes before it becomes very serious. You know, other things are like prescriptions, like you got to be on your blood pressure medication, but that's like a long-term thing. It's not an acute.
So your comment made me think of Narcan.
Perfect example, yeah. The time is of the essence. Yeah.
Injectable glucose for someone who's hypoglycemic.
Yeah.
I don't know that has been an issue.
You could give honey, you know, there's more alternatives.
Yeah, that's
Like if you're a candy bar or something, right, quick. But yeah,
They're conscious.
right.
We're frosting on their gums.
Thank you.
Okay,
I'm just curious because this is one where it's unique in that
thank you
category.
very much.
Thank you, Mr. Chair.
Okay. Next, we're going to have Sarah Teachout
Thank you.
from Blue Cross Blue Shield. If you please introduce yourself.
I will. Thank you. I'm Sarah Teachout. I'm the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. And I am here to talk about the information I can help you with on the epinephrine bill. So I guess I'd start with, yes, there is a generic to epinephrine. So the price has come down considerably from what it was, I think, and what you're remembering. So I was told by our director of pharmacy that the average price that we're paying right now for one of those packs of 2 is $135. For a pack of 2. Yep. And they do expire. And there is, so that pack of 2, the generic one, is on the first tier of our formulary. So someone who has a cost share arrangement would have no cost share because it's a tier 1 generic. So the vast majority of our members already have no cost share if they're buying that one. There is, just so you know, one, it's called, I think I'm saying it right, AUVI-Q, AUVI-Q. It has voice instructions. So it's a little thing that talks to you and tells you how to do it. That one costs $686 for 2. So we put that on the third tier of our formulary and have the highest cost share for that one. So one of the impacts of this bill, because it eliminates the cost share for all epinephrine, is that someone could get the most expensive one or the generic one. It makes no difference. You know, we've spent a fair amount of time here in Vermont trying to encourage people to get the generic versions. So this would eliminate that. And so there probably would be some increase in people getting the most expensive one because there's now no incentive to get the cheaper one. Mike Fisher already said it, eliminating the cost share doesn't lower the price of drugs. And so I always feel like I have to say that. I know it does lower the out-of-pocket amount for the person. To give you a little bit more in the fact space, fewer than 1.5% of our members have a prescription for epinephrine. So we all know someone who needs it, I think. Less than 1.5% of our members.
Members do you have
We have about 225,000 members. Not every one of them has prescription drugs through us, but the majority do. And then I was told, and I sometimes don't trust averages, but the average cost share for our members for epinephrine is $9.27. That's because they're averaging the vast majority that have no cost share, and then some that have very high cost share, either because they're buying the one that's on the tier 3, or they have a high deductible health plan and they have to pay the full amount out of pocket up front. So I think that brings me to the next, a couple other things. We already have in Vermont for the large group fully insured and the QHP plans an overall cap on your out of pocket for drugs. And I can't think about what the exact number is right now, but there is an overall cap. Then we have a $50 cap per month for insulin. So it's any insulin that you buy in a month, because some people have more than one prescription. So, and those are the two I can think of. The only other drug that I can think of that we have sort of quick, reliable, easy access to is Narcan. And that's different. I think that you don't need a prescription, or there's a standing prescription for Narcan done by, so that people can get that one very easily. And then I think the other thing with Narcan is that we know that the police and other groups all across the state keep that on hand, so people don't actually have to buy it. So that's the one drug that I can think of that's treated in a very special way. So you're adding complexity to the healthcare system by singling out this one. Well, it's 2 or 3 at this point, because we've got insulin, we've got the overall cap, then we would have epinephrine. So it just adds to the complexity of sort of the healthcare and explaining people what's covered. That, and it only really applies to a very narrow set of your population. I think the people that you are trying to help are the ones with large out-of-pocket costs. Generally, they also have the high deductible health plans, and this cannot help those people. So it just has a very limited applicability in real life. So that being said, the cost is also small because it's not helping very many people. I think what this essentially will do is, if someone has some sort of cost share plan, that somehow the first tier generic doesn't help them, or if they want to buy the higher cost one, the $600 one, this would help them get that with no cost share. That's where the impact really is. So with all that said, I'm happy to answer questions. This is, we feel like an added complexity with very little added value.
Okay, thank you. Alyssa?
Is there any reason that somebody could not use the generic? Are there any contraindications to the generic? And if so, do you have a prior authorization process for the non-generic to not make it a tier 3?
Yeah, you know what? That's a good question I can't answer right now. I thought that the generic was equivalent, but I should double check.
Can you say your question again?
No, just if somebody has, something that for some particular reason, medical reason, where they cannot take the generic, is there a prior authorization process in place where they could then have the non-generic, because they're unable to use the generic, that would then make the non-generic a tier 1, not a tier 3 on the formulary?
So the only thing, it's coming back to me because I talked to her quite a while about this, is babies. So I think because of the size of the dose, sometimes the babies need the special, one of the more special ones. That's the only thing I can think of right now.
Make exceptions on the tier 3 for.
Yes, if the patient is under a certain age, then they get the one that's the appropriate dose for their needs.
Okay, Murray?
Do you have any utilization information about the tier 3, use of the tier 3? And is it, do you know how new it is?
Oh, yeah, that's, Nancy would know all the answers to these. Nancy Hoag, I don't think it's used a whole lot, but right now it's because it's on the tier 3 of our formulary. So it's more expensive for someone to choose that unless, again, like I said, I think if it's a baby, then that one's not tier 3.
Okay,
Any idea, Sarah, on the impact on premiums?
It's very small. I do not think in the big scheme of things, you're gonna,
It's noticeable at all.
yeah.
Bobby?
Is there any way that this bill could be amended to make it so that only the lower cost one is used, or is there other reasons why that can't happen? I mean, like if, assuming that the molecule is exactly the same.
I think you could say for generic. Yeah. There's always a way.
This is an interesting question, but what would we gain by doing that if we would eliminate the access for babies? You know, that micro dosing thing.
I need to double check, but I think that if it's a baby, then it's on the first tier.
Very nice.
Yeah.
Murray?
Maybe an issue for people with disabilities too, that may need the
I was just who's,
the voice one.
yeah, who can't read, someone who, you know, whatever it might take.
Well, I don't know what language it's in, the voice one.
If I get to choose.
I have one question.
Sure, I'll try.
Is it automatic when you go into the pharmacy, if they come in for one of these kits, are they given the generic?
So we have a generic substitution law that I actually worked on 20 years ago here in Vermont. And yes, they are supposed to automatically give you the generic. I think that there's a way for the patient to get the brand if they, and say that they don't want the generic, but they have to, proactively do so. Otherwise the pharmacy.
Isn't that done by the doctor? The doctor writes
The doctor and the patient, I think the patient can also say, I really need the brand.
To that end, do we know of, have we heard of, are there any supply chain issues with the generic? Is there?
I did not even think to ask that question, so I don't know.
Well, no, it's just that I know that there's a lot of medications right now that people just can't even get. And I mean,
Okay, thank you. Leslie?
So I guess this bill came through Senate Finance, which is kind of interesting in that why it landed here, I don't quite understand this process, but there was a fiscal note. And according to the Vermont Department of Human Resources, there would be an estimated 25,000 to 30,000 annualized impact on the state of Vermont employee health plan, which is a lot more than I would have thought.
Well, that's probably going to be paid by.
Premiums.
Except for they're excluded from the bill,
I
right?
remember my question.
say something.
For the record, Ameren Aberdeen Legislative Council, the original as introduced bill had language that would cover the state employee self-insurance plan. So the Joint Fiscal Office reached out to see what that impact. But in the as passed by Senate version, it clarified that the state employees plan is not included. So
It's not relevant.
so it is not relevant to the bill as it comes over from the Senate.
So I would also just clarify that in the scope of we pay $1.3 billion in claims for Vermonters. $25,000 is de minimis.
Yeah. That's helpful to get a scope. Yeah,
That's, but yeah.
Go ahead,
What is the shelf life, Sarah, of this drug? How long do you say it lasts? Somebody knows.
I think it's approximately a year.
Okay, so, all right, so the folks that need this carry it with them wherever they go in case something happens, they're able to protect themselves.
Correct.
a year, they have to go back and replace it, assuming nothing happened in that year.
Yes.
And that's, I just want to understand the magnitude of it.
No, I recognize it's very important for people who need it.
Yeah, right. And it's, you said the copay, most of the copay is $9.
That was the average. Most of our members have no copay if they get the tier 1 generic.
Okay, so they get nothing.
No,
Right.
and it just isn't the patient. I know in my family, we had two, that set of two all the time. And we still have it. You know, our grandson still comes to the house and he may forget it. So we have it there just in case something happens.
Okay,
So,
yeah.
And at school as well.
yeah, they have it at school too.
Yeah.
Sometimes they have it with the school nurse. Yeah. Other questions? All right, Sarah, thanks very
Yep.
much.
Thank you.
Claire?
Yes.
Healthcare, if you'll introduce yourself, please.
Good afternoon. I'm Claire Buckley with Leonine Public Affairs and here today on behalf of MVP Healthcare to discuss S65. And Sarah brought up a lot of the same issues I was going to bring up, but I'll just go through how MVP covers these drugs, which, we cover both the brand name and the generic version. And the generic version is covered under the tier 1 of the formulary. Certain brand name ones are covered under tier 2. And there's one called Adrenaclick that is covered under tier 3. And finally, the one that Sarah was mentioning, which is, I don't even know how to pronounce it, but AUVQ, AUVI, and then it's -Q. That one is not covered on the formulary. However, if for some reason you needed that drug and it was clinically more appropriate, there is a way of, if you needed it for clinical reasons and your prescriber said you need to have this, we would make an exception. But at this point, it's not on the formulary. So the formulary cost shares vary by product greatly. And so typically tier 1 drugs are the least expensive and preferred. And then tier 2 are more expensive. And then finally, the tier 3 are the highest cost drugs. And so the formulary benefit design charges the lowest copay on tier 1 and similarly goes up, as the tier, the more expensive drugs you basically are going to pay more for under the way the plans are developed. So, absent insurance, I know the question has come up, and this is before the deductible absent insurance. What we've determined is the cost can vary by hundreds, going from 150 to 600. And people can find things online that show it's even more than that, but that's what MVP typically the cost is. Brand name drug manufacturers do offer copay coupons today. So what they will do is they'll pay your cost share if you use their brand instead of the generic. And I did a little online research on that just to understand how that worked. And in fact, I did find for the brand EpiPen, you got the savings card and it would do that for you. So there's that option out there right now. As was mentioned before, Vermont law sets a maximum out-of-pocket cap on all prescription drugs today, and we have those caps. So, that already increases premiums disproportionately to the cost of drugs by capping it. So, and we believe that prohibiting cost share on these drugs just masks the actual cost of these and provides no incentive to use generics, which I think was mentioned earlier as well. We think that it could result in higher utilization of the high-cost drugs. And, that may be no more effective for the patient than the generic. So we think overall, that scenario will increase premiums, even if it's, I don't have any numbers on just the scenario of capping things and then allowing no cost share so that people can have the most expensive drugs. Those types of things overall can increase premiums. And as mentioned, the bill can't apply to high deductible health plans. So, I would also like to add that, we'd ask that you be mindful of rising costs and affordability. That the cost impact of eliminating cost sharing for this particular prescription may be limited, but there's other proposals that have been introduced before this body that require coverage of other items and services with no cost share. And I think you already passed one or are thinking of passing one this year in another bill. And so the cumulative effect of all these changes could further increase insurance premiums for individuals and small groups at a time when they can really not afford it. So we'd also like you to consider the potential inequity of singling out any non-preventive care item or service for cost sharing elimination over anything else. And I think we've discussed this a little bit here, or you all have discussed this a little bit here today. It's sort of like, well, why EpiPens and not some other life saving drug, and I think that's a good question to ask. So for these reasons, we prefer, that you not move this bill forward. And I, definitely thank you for considering these comments, and I'm happy to answer questions.
Go ahead. How much did MVP's rates go up from last year to this year exactly?
I would have to find that out and get back to you, and I will write that down. And
then I'll ask another question. You'll probably have to get back to me on.
Sure.
Why do the rates go up no matter what we do? Thank you. It's the truth though. Like the rates are as high as I think the Shao study said they would have been if we had universal health care, and we don't have universal health care. So I don't know. I don't know if you can answer that, but I think just knowing a little more about why are the rates going up so much,
Right. And obviously all our costs are going up. And I'm somebody who, I'm sure that if you brought the Green Mountain Care Board or some really knowledgeable person on healthcare costs, they could give you a whole dissertation on it. But one common sense thing is that all of our costs have gone up for healthcare and insurance, and in the pandemic, buying, different things, and everyone's costs are going up. But
except to pay for the healthcare providers. Mm-hmm. Like my pay hasn't gone up. Like my MVP rate went up, but my pay didn't go up from MVP. Well, I'm just saying.
Yeah, I got you.
Yeah. But it does.
Larry, go ahead.
You mentioned that Adrenaclick was not on the formulary. Is it your PBM, CVS Caremark? That's your PBM, right? It's the PBM that decides what's on the formulary, right? Or does your insurance, does MVP have a say in what's on your formulary?
I will have to get back to you on that, although I did ask a little bit about this question. And I will have to get back to you for sure, but he had written to me that, they work with the PBM and community clinicians to make decision about formulary inclusion and placements. And the discussions focus on clinical, how well something works clinically and cost. And all formulary decisions are made by an MVP pharmacy and therapeutics committee, which includes both MVP's employed clinicians, physicians, and pharmacists, as well as clinicians in the provider network, including those with experience and expertise in treating certain conditions.
Okay, Melissa?
I'm sorry if I missed this. Sarah had indicated that their tier one is zero cost share. Is MVP as well?
I can submit to the committee a summary of all the cost sharing, but for all the plans, and it certainly ranges. And when Sarah said that, I had printed out, it's this huge document. You probably have it in front of you. Oh, yeah. And I have a slightly different one, but I tried to print, just to be able to answer. And I was looking down, for platinum, gold, silver, and I see, I would have to get back to you, but on this chart, every single one of them has at least some cost sharing, although it does have, it says, it might say $10 and then it says not subject to the deductible. That's what the NODD is. So you wouldn't have to pay your deductible and then have the $10. Even if you hadn't satisfied your deductible, it would be $10 in that particular plan, in the platinum plan. And that is for a tier 1. And then, a tier 2 is $50 and a tier 3 is 50% in that particular plan. And I'm happy to share with the committee, there's a lot of, I think that's what people do. They know what their prescription drug costs are and they know what their costs are. And then they try to say, well, where am I going to get the best deal on this chart for my family, and try to, understand what they are. But I would say no, based on this, at least in the platinum through the silver that I have on this page, they all have some cost. Yeah.
Yeah, I was confused by that as well.
And that's the difference between, if somebody doesn't want any, they choose a different carrier.
Okay. Thank you.
And I will absolutely confirm that question, that there is no MVP plan with, maybe there is one that I don't have on the sheet of paper. I'm happy to confirm that with you. For you.
Still Art's question, he asked Blue Cross and Blue Shield about the premium that would be raised if this went into effect, and then he's told it was pretty nominal. What is your understanding of do you have a sense of how much your premiums would go up?
I don't. I do know that it would be, very limited. What my point is like cumulative. Yeah.
I just wasn't sure if you had for this specific.
I don't have any specific information on, I heard you asking some questions of her of MVP's specific, universe of people, and I don't have any information on that.
I don't know who could answer this, but, we're doing this, again, this is a very important thing, but we've limited it to a small group of people. So I'd like to know why we, something so important that we've eliminated a lot of the citizens out there from enjoying. Is it the cost? Like the state employees it's not eligible?
No, we just don't have the regulatory authority to touch those. Some of them are those ERISA plans that are regulated by the federal government.
Okay, so the state doesn't have the authority.
Right.
Okay.
And we as legislators don't have the authority.
Okay.
Otherwise.
Oh, that's what I'm saying. Yeah, okay.
And is that just the high deductible plans?
Yeah, the high deductible plan also, yeah. It is, okay.
HDs.
And my understanding, is the Senate exempted that, and I think you've exempted it also in some cost sharing, mandates that you've considered in this committee, because there are IRS regulations that if the person spends anything, it's not allowed under the IRS regulations, and there would be negative tax consequences for the individual if they were waived the cost sharing in these circumstances.
Do you have any answer to that?
Not very good.
Okay. Leslie?
I was wondering if we could get your testimony in writing on the website?
Sure. I will probably work this up a little bit better.
That makes sense to you? Yeah.
What I just said about the tax liability, does
Yeah.
that mean that the fact that the cost sharing is eliminated means that you have to pay taxes on that as like income?
Can
Just trying to understand.
I think you're.
For the record, Ameren Abergele Legislative Council, I would need to look more into it, but the bill, its language itself is excluding high deductible health plans that have the health and savings accounts, because federal tax law doesn't allow the insurer to be the first person to pay if you already have those health savings accounts, because you do get tax advantages by having those, right? So you don't get the advantage of both at the same time.
Okay, other questions?
Again, I'm trying to understand just what this bill, the impact it has on people's pocketbooks. Does anybody pay a lot of money today, if they're insured, for this epinephrine? I mean, does anybody on the hook for like $400 for it? Or it sounds like 99% of the people pay like $10. Gonna get it $10, and that's your cost probably for the year. Yeah, I just asking. Do you know what, you may not know.
I don't think I can answer that question. I'm happy to provide
So I
MVP's
understand.
like list of all the cost share. I would have no idea what 90% of, I mean, I don't know.
Do you have anything to add to that?
If I have the menu.
We're in trouble. Multicolored.
Which is why I spend all my time like that close to it.
Mike Fisher. I think the answer is no. Nobody's paying full fare other than the uninsured person who's not affected.
Right.
You know, we're talking about the cost sharing amount for a single script. And so it's, you know, with a little bit of time, I can give you an idea of what different plans would charge for that, but it is a smaller amount than the $400 example.
I just curious.
Clint, can you tell us, I think you said that you didn't know what the percentage of your patients were that would be.
I don't, but I can find out when I submit it in writing.
Yeah, that'd be a good idea. You gave us yours.
Yes.
1.5.
Less than this 25%.
Okay, committee, any other questions? Thank you.
Thank you.
Thank you.
And this is the end of the session for the Healthcare Committee today.